Now it's my pleasure to introduce the last session of this exciting meeting. The theme of the session is blood flow and vasculature. And the first speaker will be Michel Atlan from the Institut Langevin. We'll talk about high bitrate digital holography for ophthalmology.
Thank you, Michel. Can you hear me?
Yes, I do.
Excellent. So I will start screen sharing. Can you see the screen?
Yep, we can see it.
You can, right?
Yeah.
Okay, let's start. So I will speak about high bitrate digital holography for ophthalmology and try to give you some insight about what I've learned and what I think the future will be at the end. So yes, I work at the Langevin Institute in Paris, and but mostly most of this work has been done in Michel Paques' teams in the Clinical Investigation Center of Quinze-Vingts Hospital in Paris. So what we do basically is to shine the eye of patients with near-infrared laser light at the natural, and we focus the light at the natural focus point of the eye, and then the light is expanded onto the retina. Typically it's very comfortable for the patient. It's about 3 milliwatt of 850 nanometer wavelength light that changes the retina and comes back through the focus point here and through an imaging lens, and then it makes an image in this plane represented here. But the thing that we do with this kind of holographic imaging is to not to put the sensor plane of the camera in the imaging plane, but a little bit aside from it in order to sample a diffracted field. And this diffracted field that you can see here is mixed with some light that we call the reference that does not go into the eye of the patient. And that is something extremely important here. We can perform coherent amplification of the wave field that comes back from the eye of the patient without shining the eye too much and managing to illuminate a typically very high-speed camera, about 60 kilohertz, 60,000 frames per second at half saturation. So the camera always sees a lot of light, and so we don't have any problem of a signal-to-noise ratio for recording those diffraction patterns, those interference patterns. So we use a high-speed camera and what I call a video rate camera that is still a few thousand hertz. Okay, and we record the mix between the photons from the eye and those interferogram patterns. And from there, it's only a matter of calculations, digital calculations, to create our images. But just before that, I will briefly show you the latest instrument. So we shine the eye of the patient with the light that comes from the white optical fiber that goes here, bounces onto the tube here. The eye of the patient is here. The photons go back onto this small camera and the fast camera here. And the wave field is mixed with the reference wave that comes from the red fiber here and onto the two camera. And we collect that interference pattern. And the calculations enable us to calculate power Doppler images. And I will explain basically how we do that in two very simple steps. First, we do a wave propagation. So each image is subject to a wave propagation, angular spectrum propagation, or even a Fresnel transformation. It's very well known and easy to do and easy to parallelize onto GPUs. And then, as you can see on this image, there is something that is hidden in the fluctuation, in the temporal fluctuations of each pixel that we can reveal with the temporal Fourier transform. And if we take a bunch of 50, 100 frames, typically, we still get a very, very high temporal resolution, and we get a power Doppler image in very good conditions. And these Doppler images enable us to reveal pulse waves into the vessels of the retina, here typically in the papilla of patients, and discriminate arteries from veins. And the good news is that it works in pretty much all the patients that we've been able to monitor, and even in cases of cataracts, but I will get back to this a little bit later. And the kind of signal that we collect is this beautiful signal of pulse waves with a systole followed by a diastole, and you can even see a dichrotic notch that attests that shows basically the elasticity of the arterial walls that we will even be able to quantify in the near future. All this kind of imaging is performed very robustly through singular value decomposition that I will very rapidly introduce here, that in opposition to Fourier analysis will enable us to, in cases where for instance, the global motion of the eye, the Doppler response of global motion, which is represented here, or other artifacts that will give parasitic contribution, will be overlapping onto the Fourier spectrum. Well, we can discriminate the two. Here is the contribution in Doppler response of small vessels. Typically, we will be able to discriminate them a little bit better than with Fourier analysis with singular value decomposition, which is typically a diagonalization of the signal from several images. And with this technique, we can get rid of parasitic reflections, bulk motion, and camera jitter much better than simple Fourier analysis. Okay. In addition to singular value decomposition, we can perform digital rephasing. We've had some talks about that, and what we simply do is to adapt the work from the two references here that performs a Shack-Hartman analysis. So I will get back a little bit to what we do here. So we record the interferograms into the diffraction plane here, and from them we compute the images in the image plane, which is the conjugate of the retina plane here. And then we move the signal into the reciprocal plane of the image, which is not very far from being the plane where you will experience aberrations. Okay, and from this plane, in this plane, we will divide the field of view into chunks, here 4 by 4, and in each chunk, we will get back into the image plane in order to create a smaller image. And these images, we will use one as reference, and we will compare the position of all the other ones to given one that will be treated as a reference, that will give us a deformation that we will project onto a set of Zernicke polynomials in order to basically assess the phase screen that creates the aberration in order to use its conjugate in order to get rid of the aberrations and improve image quality, spatial resolution of the images. In practice, it looks like this. So in a patient that has strong astigmatism, typically about 2 diopters here or even a little more, you cannot do a better refocusing than that, typically. So in order to reveal the astigmatism and compensate it, we divide the image into image chunks, do the calculation through cross correlation. We compute the distortion field that we project onto a set of elementary lenses in order to compute this astigmatic dynamic lens that we use to improve image quality. And it works, as you can see, very, very well. One thing that we want to do with that is to make it more reliable and quantitative. So we need to assess the number of diopters of the system with that. It's not done yet, but we're quite confident that we will be able to do that in the near future. So, of course, the combination of a singular value decomposition and rephasing aberration compensations improves very much the quality of the images, as you can see here from left to right. We can also compute color images of blood flow that will typically be done at from a low frequency power Doppler map that will reveal very small vessels and the fluxes in the very small vessels, and the high frequency power Doppler map that will reveal higher flows. We can colorize all of that and get this beautiful colorized image. We can automatically compute images during systole, diastole, and then reveal discriminate retinal arteries and veins. And we can even calculate the dissymmetry, the asymmetry of local Doppler spectra because of holography. That is very important to reveal. If we compute the positive Doppler shifts and the negative Doppler shift, the image will be very different. And the combination of the two, if we colorize that, will reveal the blood flow in the central retinal artery and the central retinal vein quite quantitatively. Okay, we can also calculate the modulation depth of the pulse wave locally. That will give us the resistivity index that is commonly calculated with acoustic methods, and all of that can be done automatically and in parallel to have this slide, for instance. Okay, now I will move on to something that Leo Pouillot has presented before, which is anterior and posterior segment imaging. With the same data set that we record, the set of interferograms, we can either propagate the wave field into the retina plane and have these images on the first row here, but we can also calculate very different images. The processing is very different. Not only do we calculate the wave field into the pupil plane, as you can see here, but we also do the things very differently, and so we can reveal the transparency of the anterior segment, which is very clear here in healthy volunteers. And if you see on the right, you can see the effects of starts of cataracts and some stains in the anterior segment of patient. But that does not prevent very clear imaging in the eye fundus. That is something to very interesting with this technology. Okay, So now let's move on a little bit to some clinical uses in retinal and choroidal blood flow visualization. So Doppler holography compares very well to the state of the art, which is ICG injection and even OCT. But the difference is that it will give you a dynamic signal, and it will, in particular in the choroid, it will enable you to have this clear discrimination between arteries and veins, which is extremely valuable. Okay, let's have some cases of blood flow monitoring in glaucoma, for instance. As you can see here, you have the same eye, same region of the same eye of the same patient, 2 hours apart. So here, the first image, the first movie was taken in a patient with high intraocular pressure of about 38 millimeters of mercury. And as you can see, the blood flow is impaired, especially during the diastole. As you can see, the blood flow doesn't give any Doppler response during the diastole, which means that it is impaired in a long period of the cardiac cycle. And just after filtering surgery, here the intraocular pressure goes down, and as you can see, the Doppler response is much more present throughout the cardiac cycle. So there is a consequence of high intraocular pressure onto the hemodynamics that laser Doppler holography can reveal. And here is another patient with the same pathology, but the images were taken basically, I would say, a week apart. So the effect is a little bit different, but it's the same effect. Okay. We've also seen carotid artery stenosis. Here, 100% stenosis will give you a blood flow that you can see in the right eye of this patient that is very much impaired. And in his control eye, the situation is very different, hopefully for him. You have another patient with the blood flow impaired in the left eye due to carotid artery stenosis from the left. And the control eye, of course, is better. You can also monitor retinal occlusions. Okay, here you can see a stenosis of the artery, local stenosis over here. You can see a branch, the retinal, arterial, the branch artery here, its blood flow seems to be impaired. The pulse wave is intermittent here. It's because of the flow that goes back into the vein. It is probably occluded in a given region here. So there is an arterial consequence of vessel occlusion. Here again, we have a central vein occlusion, and with arterial consequences that we can see on the laser Doppler images. Okay, here it's revealed a little bit better. It is the vein over here that goes back here and create even shunts over there that was completely occluded 27 days before the image on the right, as you can see here at D0. Okay, I see that I'm running out of time. I will try to move to the fact that we can compute these things in real time now with streaming cameras. So we move from cameras of about 60 to 75 kilohertz to more modest cameras, but which have the capability of doing the recording in real time. And we tried to do the calculations in real time, and we were successful. But the thing is that we had to do a little trick, which is not to record the typical Doppler response of the that we can, because when we have a very, very large bandwidth, so we had to get the typical Doppler response in a narrower bandwidth with a streaming camera and reverse the signal. And 6 months ago, we were able to do these wonderful images in real time. It's very important because it's a major milestone for us to enable real-time imaging. And we can even do that in the anterior segment, as Leo Pouillot has showed a little bit before, and even in patients with lesions. Okay, and very recently, 2 hours ago, Egidius was talking about...
2 minutes again, Michael.
Sorry?
2 minutes left.
Yeah, I'm almost done. Egidius has said that optical coherence tomography with a very high-speed camera was difficult to do in real time, and that is the reason why they use a linear camera in here in order to have a real-time visualization of the image, and in order to perform those 3D images, which are typically acquired 1,000 times faster than with current technologies. But I would say that hopefully, and because they have given us some data that they have acquired with a very fast camera, we can now say, and we have proven here, as you can see, that these calculations can be done in real time, and that is very important. So today we are able to perform real-time laser Doppler imaging and real-time optical coherence tomography. Okay, and I think I will just end my talk here. I'm sorry. Okay, thank you.
Thank you, Michael. I would like to hear you for hours again, but sorry, we got other people to, they have their talk managed. So now the next speaker, I'm introducing the next speaker, which is Richard Rosen from New York. The title of the talk is Exploration of Preferential Site Vulnerability of Capillary Occlusion in Sickle Cell Retinopathy using OCT Angiography. Richard.
All right, to the more mundane. That was a great talk, really amazing stuff. Let me see if I can share my screen here. I think you need to stop sharing. Oh wait, there we go. Okay. So this is really some great talks this morning. I really enjoy them. Today, I'd like to share with you some of our work. I'm Richard Rosen from the New York Eye and Ear Infirmary of Mount Sinai. My topic is a little bit different than what's listed. It's sort of a combination of topics: quantification of preferential site vulnerability and intermittent capillary occlusion in sickle retinopathy using OCT angiography. Let's see. First, I want to acknowledge the work of my team, especially Toko Chui, who's done the heavy lifting and a lot of development work, and some of the work done by Alf Dubrow and some of the adaptive optics stuff locally. Justin Mujat and Oscar Otero have done, most recently been involved in a lot of this work. So these are our disclosures and funding sources, and none which are relevant to this talk. So sickle cell disease is the most common inherited blood disorder, and it's involves a single point mutation on the beta hemoglobin protein. And systemically, we see that there's a difference between what happens systemically in terms of the retina. Systemically, the sickle SS hemoglobin is worse than sickle SC, and then the other variants follow. But in retinopathy, the sickle SC is worse than sickle SS variant and the other variants which follow. This is a picture here on the right of proliferative sickle retinopathy here. So vaso-occlusion is really the pathological hallmark of the disease. And largely this is due to the fact that under low oxygen conditions, the sickle hemoglobin autopolymerizes, and which increases cell stiffness and distorts the morphology and blood viscosity and results in these occlusions. The concept of where the pathology is occurring largely came from some work that was animal work done by Fernet, where they proposed that leukocyte adhesion in post-capillary venules were the site of the actual occlusion and primary pathophysiology. And you can see some work that's done here in these mouse venules, where you can see a few cells that are stuck on the surface and some white blood cells that seemingly are causing the blockage. And this has sort of been held for some time. So OCT angiography is a tremendous clinical tool that we've embraced over the last few years. It really gives us the ability to do sort of vascular imaging, but in a quantitative mode. So we can do a lot of investigations that we really couldn't do very well with fluorescein angiography. And some of the work that's been done in our lab and looks at we sort of developed capillary density mapping and then a deviation mapping, largely through the work of Dr. Chewy. So the purpose of this study was to really quantify and try to understand what the preferential site vulnerability of the capillary occlusion in sickle cell retinopathy was, using some techniques of OCT angiography. So we looked at 18 patients with sickle cell disease and 17 controls, and they were actually imaged at 2 different time points an hour apart. So 5 of them were sickle SC and 9 were hemoglobin SS. They were treated, and then there were 4 that were untreated hemoglobin SS. And the treatment is using hydroxyurea, which changes the composition of the blood cells and reduces the number of leukocytes. So we take 10 sequential 3x3 OCT angiography scans, which we look at the temporal retina, 9 degrees eccentric to fovea, and the scans are then spatially registered and aligned and averaged. So here's an example. So the veins and arteries are actually identified using a color fundus photo. And so here you can see veins and arteries here. There is a skeletonization that's performed with MATLAB. And then we look at a region of interest, which is 300 microns in diameter, that are comparable on adjacent veins and arteries. And then from here, we can actually look at the capillary density of these regions of interest, which are comparable in size. We took 2 pairs to see if they were relatively similar in terms of the outcomes. And here you can see in a control eye that the results where you have fairly comparable amount of density between the arterioles and the venules. But as you go on to diseased eyes, sickle cell, you can see that there's starting to be some slight. These are fairly close. These are treated, but in the untreated, you see a decrease in capillary density. And if you look at the images, you can actually see that there appear to be dropout in some of the small capillaries. And when you get to the level of the hemoglobin SC, which is much worse, you can appreciate the fact that a lot of these capillaries have sort of disappeared. Here's a side-by-side comparison showing you two. And when you look at the numbers, you can actually see that the venules really don't change. There are no significant differences. So in fact, the difference appears to be at the level of the arterioles. And you can see that they've definitely decreased as we go on to severity of disease. So this is just one small aspect of what we're going to share today. But it appears that the more vulnerable site, at least according to this way of measuring it, are the arterial or capillary junctions. And so this is a technique which may ultimately be useful for looking at vulnerability of specific occlusive disease. The other aspect I was going to share with you is quantification of intermittent capillary perfusion using sequential OCT angiography. And here again, as I mentioned, the quantitative aspect of OCT angiography is tremendous. However, it really only captures a single snapshot of blood flow. And so if you look over a sequence of time, you can actually appreciate in this 10 OCT angiography sequence that there are vessels which open and close. So depending on when you capture the image, you may get very different readings in terms of what your outcome is. And I think that that's something that clinicians, we tend to be rushed to see patients, a lot of patients very quickly. And so we get an image that's done by the technician and you can't determine. So there's probably some degree of variability and artifact that's instilled by this variability. One of the things we've done is actually use adaptive optics to study this intermittent flow a little bit more carefully. And here you can see in this small segment along the FAZ that the area that's blinking is where you have a rouleau of RBC, and you can actually, if you zoom in a little bit closer, you can see that there's a single torpedo-shaped sickle cell. These images are taken with our quad detection system, which was developed by Alf Dubra, and the details of that system are described in his recent paper. We have another paper that's in press, so it has a little more about the processing. Here you can actually see the average image, and what we actually can get down to the level not only of looking at the intermittent spacing, which you can see here again on the left, but we can see various morphologies to the red blood cells. So these have been described previously in vitro studies, the discocytes, the teardrop shape, and the parachute. And you can see them here in vitro capillary images. So in this particular aspect of the study, this part of the study, we wanted to develop a metric of intermittent capillary blood flow in sickle retinopathy using OCT angiography, and then to, of course, look at the dynamics of what was going on in these areas using our adaptive optics scanning light ophthalmoscopy system. So the method was to acquire these 10 sequential scans at 2 different time points an hour apart. The images were averaged. The larger vessels were removed. So in the area of the FAZ was removed. So we actually could subtract and look just at pure capillary density differences between the two. And then the distribution was mapped. And we basically looked at the greater than 99.9% and lower than 0.01% with the Bland-Altman statistic. And that gave us a normative reference. And based on that, deciding which was a normative amount of variation which you would see in the controls. So the original controls were used to base that. And here you can see side by side session 1, session 2. And when you look at the OCT angiograms, it's pretty hard to tell. But when you look, the mapping ultimately shows you the intermittent areas of intermittent diffusion. And there's really, they're pretty comparable in terms of the areas of the two. If you look, you zoom in on these small areas, you can see that they're where the vessels have disappeared, and they're marked here on the right. And if you look at another area here, which would be considered to be a reperfusion area, you can see where the vessels which weren't present in the first session are present in the end. So as I mentioned, there's no real significant difference between these. And then of course the subtraction of the two gives us the intermittent flow map. Here are some examples of patients with different genetic types who all had sickle cell disease. And you can see there's quite a bit of variability in terms of non-perfusion and reperfusion. The areas, when they were mapped, there's no real significant difference in terms of size, which you would expect, because, you know, it's really when you happen to catch it. If you catch it when it's on or you catch it when it's off, it's going to, you know, the next version will be either reperfusion or non-perfusion. However, when you look at different pathologies, there is quite a bit of difference, and there is some significance between the different groups. So this may actually give us a way of measuring what the activity of the disease is at a momentary basis. Now, ideally, it would be good to be able to do this in an instant for the clinician, but most of this processing is, of course, taken and done offline. Here you can see an example of a patient who's had treated with hydroxyurea, and you can see pre-treatment, there's about 2% of the scanned area represents some of these areas of intermittent flow, whereas 2 months after the initiation of therapy, it's reduced almost 5-fold, which is significant. And of course, hydroxyurea is one of the mainstays of treatment. There are new generations that are coming up, but this is currently the best thing that we have outside of gene therapy. So I'm going to show you what the adaptive optics looks like in some of these areas. You can see the picture here in the upper left. So you're looking in this region of interest. And here you see on the pre-treatment, you've got sludging as pointed by this yellow arrow. And of course, post-treatment, the same area, you can see that there's constant perfusion. You look at another area of the disease, you can see that here's another congested rouleau, which you can appreciate with the red arrow. And of course, in the later images, 2 months post initiation of treatment, the flow is restored. Interestingly enough, here's a another area of the picture where you see constant perfusion before treatment, and now you see a rouleau that's developed. So it's obviously not a perfect treatment, and there's probably some interaction between the fact that there are some areas that are clogged in the pre-treatment that then become open. So there's more dynamics that we haven't yet explored. Here's another area of the around the FAZ where we compare these different images. And here you can see sludging at the yellow arrow on the left. And as you look into the right, you can see that the flow has been restored. Here's another area similarly where there's no flow in this one particular vessel, which then opens up following treatment. And then finally, here's another vessel which was blocked by the occlusion down below, which now is restored as well. So serial OCT angiography and intermittent flow maps actually reveal sort of these transient perfusion changes, which are really not available from single OCT angiography scans. And quantification of this fluctuation really offers a metric of the vaso-occlusive burden, which may be important in predicting the possibility of more serious occlusions. The eye is in many ways the canary in the coal mine for a lot of the disease that is occurring in other parts of the body. We know that these patients suffer from occlusions that occur in the spleen, in the kidneys, throughout, and have painful crises. And so this may be a method for determining really what is their vulnerability. And of course, OCT angiography explains a lot of what we can see with the adaptive optics really explains a lot of what we can see with the OCT angiography. And the two of them really provide sort of a complementary techniques for understanding a little bit more about the clinical features of this disease. And I think this may be useful because we're, with the group at the medical school, we're in the process of trying to implement this for looking at the value of certain new therapeutic approaches. So I thank you for your attention.
Thank you, Richard, for this marvelous talk. I really believe that sickle cell is a fresh, very good indication of AOCT, since it can help to monitor treatment and see the effect of the actual effect of treatment. I'm very impressed by your work on that topic.
Thank you.
So since we have to keep on track with the timing, we'll have questions at the end of the session. Now I'm going to introduce the next speaker, which is myself, because Dr. Saad cannot deliver the speech herself. So she gave it to me, and I'm going to talk about adaptive optics ophthalmoscopy in malignant arterial hypertension. So sharing my screen. Is it good for everyone? You see my screen?
Yes.
Thank you. Good. So I have no conflict of interest related to this talk. So as you all know,
we actually see the presenter view. So if you wanted to flip the view, we'll see the proper one. Sorry.
I don't know how to change the view paths. How do I change that? Now, is it correct for you?
Just hit the presentation mode, and I think it should come back. The lower right-hand corner, the little icon there with the square.
I mean, on the Zoom or on the PowerPoint?
On the PowerPoint, you had it. You were right there.
No,
and then at the top there, there's a parameter that you could change. It's in French, but it's just swap presenter view is the thing you want to change there.
Oh.
Once you go back into your slides,
Yeah.
Yeah, back where you were.
There.
Yep. And then at the top here, there's if you go to the upper left corner, there should be a little icon to say swap presenter view. Perhaps Kate, you could translate.
Afficher. No, I completely lost the. Okay, maybe I'm going to change my strategy. I'll stop the screen sharing. I'll put the.
It seems maybe you have two screens and it's trying to show the slides on one.
I'm going to start on one of my screens. Okay, so let's see if it works now. I'm just going to close it and open it back. No, not solve the problem right away. Just last try, and I think I'll go to the next speaker and talk after next time. Let me try one last. Okay, now. Okay, got it now. Okay, so as if the next speaker is there, which is I even lost.
Yes, I'm here.
Are you there?
Yes.
Can you deliver now your talk on vascular biomarkers in adaptive optics ophthalmoscopy?
Yes.
Okay, thank you, and I'll try to solve my problem during that time. Go on.
Okay, so I'll share my screen. Okay, good day, everybody. My name is Roan van Bakel, and today I will present a systematic review about vascular biomarkers in a retina in adaptive optics ophthalmoscopy. The research was performed by researchers from the bigger eye group from the Erasmus Medical Center and the eye imaging group from Paris. Today, together we managed to perform a systematic review about retinal biomarkers. These are our findings. And the motivation for this research was to describe the current state of retinal biomarkers imaged by adaptive optics systems. Adaptive optics is a technique coming from the astrology where light deformations can be corrected for and therefore create higher resolution images. In the eye, this can be applied to enhance retinal vessel visualization. And since the commercialization of the adaptive optics flood illumination ophthalmoscopy systems, a lot of research is done on the microstructures of the retina. Photoreceptors and retinal vessels can now be observed with high details, up to the point that the wall thickness of a vessel can be measured. The thickness of the vessel wall varies between individuals, but some internal processes have influence on the development of the wall, and this variety could possibly be a biomarker. A biomarker is a characteristic by which a particular pathological process or disease can be identified. There's a bunch of biomarkers to be found in the retina vessels, which obtain information about whether someone has developed diabetes or hypertension. When left untreated, diabetic or hypertensive retinopathy can be developed in the eye, and this may result in total or partial blindness. Early detection of these biomarkers is therefore of utmost importance. And some of these biomarkers are not visible on conventional retinal imaging, and therefore adaptive optics is needed to create images with higher resolution. The addition of adaptive optics makes it possible to quantitatively obtain biomarkers to objectify the presence of certain biomarkers. Therefore, our research focused on the quantitative retinal vessel biomarkers. We wrote a systematic review including meta-analysis about retinal vascular biomarkers, where a comprehensive collection is formed of the most described biomarkers. The relation between certain diseases and the biomarkers have been examined, and some promising conclusions could be conducted. The review is available on PubMed and accessible to everybody. In this presentation, I will clarify the current state of the art of the retinal vascular biomarkers in adaptive optics imaging. And we started our journey by searching the largest databases of scientific articles for articles which mentioned biomarkers in the retinal vessels with adaptive optics. And we specifically excluded articles where scanning laser ophthalmoscopy and flood illumination ophthalmoscopy were not the used imaging modalities. Also, articles where no relation was described between a biomarker and a disease were excluded. And the review after this process, we ended up with 43 articles to include for analysis. And as mentioned, only studies where imaging modalities was either SLO or FIO were included. While SLO has the advantage of capturing dynamic and blood flow related biomarkers, is FIO able to capture the wall characteristics with high precision. A lot of biomarkers have been mentioned and the relation with different diseases has been investigated. And 5 of the biomarkers, however, received the most attention. In this presentation, I will therefore focus on the wall to lumen ratio, inner diameter, wall cross-sectional area, outer diameter, and the parietal thickness. The other biomarkers showed some interesting relations with diseases as well, but unfortunately, the total amount of studies performed on these were too small to draw strong conclusions on. And for clarification, the outer diameter is the total diameter of a vessel measured on an adaptive optics image. The outer diameter is the combination of the inner diameter and the parietal thickness, where the inner diameter is the shortest distance from wall to wall, and the parietal thickness is the thickness of the vessel wall. The wall to lumen ratio and wall cross-sectional area can be calculated from these parameters and are therefore called secondary biomarkers. The wall to lumen ratio, however, says something about the thickness of the wall in relation to the thickness of the entire vessel, and it is therefore a strong quantitative parameter to be compared between a healthy population and patients. Also, multiple diseases have been mentioned in the examined articles, but hypertension and diabetes were investigated a lot more when compared to the rest. Diseases such as vessel occlusion, retinal vasculitis, and open angle glaucoma have also been investigated, but here again, no strong conclusions could be drawn. Hypertension and diabetes are important diseases to detect through the eye, as they can lead to hypertensive and diabetic retinopathy. And in order to adequately treat these patients, early detection might be essential, and we can prevent hypertensive and diabetic retinopathy-related blindnesses. In a group of studies where hypertension was researched, meta-analysis could be performed. And for 4 different biomarkers, the studies were comparable enough to conduct meta-analysis. And in these tests, hypertensive patients are compared with a healthy control group. And in this forest plot, the length of the horizontal lines indicate the confidence interval, and the size of the square indicate the weights of the studies. For the wall to lumen ratio, the result of 6 studies are compared. The center of the diamond on the bottom shows the overall mean differences. And in this case, a significant p-value was concluded. This strongly suggests that the wall to lumen ratio can be used to identify patients with systemic hypertension. This is not the case for the wall cross-sectional area. With the results of 8 studies, we can conclude that this is not as strong as a biomarker for hypertension as wall to lumen ratio. The parietal thickness as well as the inner diameter showed significant differences, but this should not come as a surprise since the wall to lumen ratio consists of these 2 parameters. This result may be useful when screening for hypertension is desired. Even early detection should be possible with this information. So the patients are not even experiencing any symptoms, but detection in the eye is already possible. The chances of developing hypertensive or diabetic retinopathy can therefore be minimized. If more diseases have significant differences between healthy and the population and the patients, then more diseases could also be detected with adaptive optics imaging in the screening setup. So diabetes has also been researched a lot, but the most important conclusions that are that the parietal thickness and the wall to lumen ratio are significantly different in diabetic patients. Also, the blood velocity, the presence of microaneurysms, and the tortuosity of the vessels is significantly different between diabetic patients and the healthy controls. And besides the aforementioned results, a few important aspects are open for discussion to us. First of all, while reading the articles that we included for the review, we notice the variety of terms that is used with the same definition. This can be confusing, and we therefore propose a normalization of terms. And we made a complete list with all the biomarkers with a clear definition. We made 3 subcategories: the dynamic and static quantitative biomarkers, and a third subcategory, qualitative biomarkers. A second observation is about the location where biomarkers are measured. These locations seem not to be defined properly, and most studies measured on the most studies measured on the supratemporal vessel. We wanted to suggest that as the location where all biomarkers should be measured for more comparable results. And the third point is to encourage research groups to investigate the entire spectrum of retinal vascular biomarkers. We have only discovered the tip of the iceberg here. A lot of different biomarkers are mentioned in the review, but a large proportion is not yet described extensively. Who knows what variety of diseases are detectable in the retinal vessels? And the final point is about the standardization of the studies we addressed, can be addressed as well. Many articles described a relationship between diabetes and some biomarkers, but a meta-analysis could not be performed. The differences in measurements and image device make meta-analysis very unreliable. If these studies were more heterogenic, we think that early detection of diabetes could be proved. So in conclusion, the inner diameter, parietal thickness, and wall-to-lumen ratio are significantly different in hypertensive patients when compared to the healthy controls. Therefore, they have potential for assisting the diagnosis and follow-up of hypertensive patients. And if we want more diseases to be detected with AO imaging, more research is needed. If there are any questions, please ask, and thank you for your attention.
Okay, thank you very much. I think I'm back on track. And are we on time on 12:30 for the talk? 12:10. We got 5 minutes for questions, or maybe we can. We'll have time for 1 or 2 short questions about your talk. Nothing in the Q&A. Sorry, I missed your talk for most of it because I have some technical issues. So.
No problem.
Okay,
Any
so
questions?
If there's no question, I'll go on with my talk. I'll talk of Dr. Saad, who's not there, and now hopefully the screen sharing will work properly. 3, 2, 1. I'm still in a single screen. I don't understand what's going on.
Right there at the top, you can change the parameters to swap presenter view.
I don't see that.
Right there, the settings parameters to change. Yeah. Swap.
Yeah.
Perfect. Perfect.
Okay, so as you may all know, hypertension is arterial hypertension, not ocular hypertension. Arterial hypertension is a major cause of loss of quality of life due to brain, kidney, or heart disease. And of course, there are some ocular complications, such as the RVO, for instance. However, there is currently no quantitative classification of severity of hypertensive retinopathy. It's mostly based on fundoscopic appreciation by the ophthalmologist. And this is a most recent classification proposed by Wong and Michel in 2004. With 3 grades, one addressing to arterial, the second one to capillaries, and the third one to optic disc, which is the most important criteria of severity, which is the disc edema. Recently, OCT have been applied to understand the macrovascular damage due to hypertension, especially OCT angiography. And several papers have shown that indeed chronic hypertension and the hypertensive crisis as well are associated with significant reduction in retinal and choroidal capillary perfusion. And this is independently of retinopathy itself. The grading of retinopathy that was described on the slide before is not strictly related to capillary loss, but this capillary loss is related to end organ damage, which makes it very interesting to predict the end organ damage in these patients. But the mechanism of such capillary loss remains rather uncertain. It's maybe due to capillary occlusion or to arterial occlusion. It's not been solved yet. So we've been interested in hypertensive retinopathy for quite some time now. We've been doing RTX1 adaptive optics ophthalmoscopy in some patients. The RTX1, as you all know, allows to see the vessel, the wall of arteries, and to measure the wall-to-lumen ratio, and also to detect focal abnormalities that may affect arteries, such as focal vasoconstriction, for instance. So we published, along with other teams, a cover paper on the morphometry of arteries during arterial hypertension. And this is the method for measuring the wall-to-lumen ratio. This is an ophthalmoscopic view that we consider a segment of the vessel, and this is segmented over more or less long distance. And we can extract these, what we call morphograms, with thickness wall, lumen wall, and a total outer diameter, and from which we can calculate the wall-to-lumen ratio along the vascular segment. And this is the results of the relationship between blood pressure and wall-to-lumen ratio, and not surprisingly, there is a correlation, even if the standard deviation is quite wide. And also the interest of adaptive optics is to detect focal narrowing, which are probably due to chronic vasoconstriction, since if you consider the lumen diameter, it decreases to a minimum here. But if you consider the thickness of the wall, it practically does not change. That means the wall, the two outer and inner wall remain parallel, meaning that it's probably not thickening, focal thickening of the wall, which can be sclerosis or some kind of degenerative process, but most likely vasoconstriction. And indeed, as I will show you some example, most of these focal narrowing may resolve if you wait long enough, indicating that indeed it's an active process. So the general conclusion of this paper is that chronic high blood pressure is associated with increased wall thickness of retinal arterioles, but not with increased wall cross-sectional surface. I mean, there is no more tissue, it's not thickening of the wall, it's vasoconstriction. And focal narrowing of arterioles are probably a manifestation of vasoconstriction, not of sclerosis. But we were quite disappointed when we followed up these patients with chronic hypertension under treatment. And we were interested, of course, understanding if does treatment alters wall-to-lumen ratio? Can wall-to-lumen ratio be used as an indicator of appropriate treatment, such as HbA1c for diabetes, for instance? The answer is probably no, because we observe very little change in these chronically treated patients with moderate levels of high blood pressure, 15 or 16, making us wonder if it could be used as a monitoring tool. This may change if we consider not only one vessel segment, but maybe the whole arterial tree. But capturing the whole arterial tree in patients is quite time consuming, and I'm not sure it can be used with the current technology on a wide scale in patients. So that's why we switch our interest to malignant hypertension. Hopefully, these patients will present more severe damage and probably better response to therapy, what we're looking at. And so malignant hypertension is, let's say, a crisis of acute elevation of arterial pressure in more than 200 millimeters of mercury. It's still a frequent disease, and it can be the first manifestation of arterial hypertension. And it can be both sight and life-threatening for various reasons. So the fundoscopic aspect of malignant hypertension is well known. You have hard exudates, soft exudates, and disc edema mostly. And on lower left here, you see an example of serous retinal detachment affecting the macula. And in other cases, we can have arterial occlusion, as you see here, and this is corresponding infarct of the inner nuclear layer that you see. The mechanism of malignant hypertension are not well known. and the consequences of this can affect many organs. So these patients are usually in an intensive care unit for it's more or less 1 week, 10 days. And then afterward, they're sent to our unit for ophthalmological workup. Next slide. What's happening with this? There it is. Malignant hypertension is not only a disease of middle-aged men, it may also affect young women, especially when they're pregnant. It's called eclampsia or preeclampsia, and gives with much lower values of arterial hypertension. It can give something that resembles malignant hypertension. It has to be treated the same way. So we published the first paper about the incidence of ocular damage as seen by OCT in malignant hypertension, and we're surprised to see that nearly 1/5 of patients had evidence of infarct of the internuclear layer, as you see here, for instance. And this is another case in which you see a thinning of the internuclear layer, which is indicative of an infarct of the retina. So, and probably by looking more carefully to all patients on larger field scans, we'll see more of these cases. So this encouraged us to look further into the mechanism of such occlusion. So the question we were asking ourselves was, first, following acute hypertensive crisis, how to evolve the arterial diameters and capillary perfusion? And second, is capillary loss related to arterial occlusion and or to diffuse capillopathy? So this was a prospective study, and the patient from which patient were recruited at an intensive care unit at the Hôpital Tournon in Paris. The first examination was not done the day of the diagnosis because these patients don't have time to do ophthalmological examination. They go to intensive care unit, and then once blood pressure is equilibrated, then they can go back home. Before going home, they come to our unit, when we perform the classical examination, fundus photography, OCT, and flood AO, and the OCTA with the fixated examination is then repeated, usually at 3 and 6 months, and sometimes further. So these are the first 11 patients we recruited for our study. The mean age was 42 years. There was a majority of men. Most of them were overweight. Half of the patients have essential hypertension, meaning that no organic cause was identified, and some other had kidney disease, and one had preeclampsia. One of the two women had preeclampsia. There was a glomerular filtration rate was subnormal. Most has some kind of kidney damage, but cardiac function was mostly normal. And on the right, you have the graph of the evolution of blood pressure during follow-up. You see the red is systolic and blue is a diastolic. And you see that the red is over 200 and reaches 250 in the patients. So our protocol comprised extensive photography of arteries, which may be difficult if we have dyslipidemia, which blurs the contour of artery. That's why our primary goal is to capture the arterial diameter and volume ratio in one specific area, which is vertical to the fovea. So you trace a vertical line going through the fovea, and the first artery that you meet is a transverse artery, and 90 or 95% of patients of eyes show that an artery at that location. And we choose usually the upper one, but we can choose the lower one if the artery is too small, or if, in this case, for instance, there is an infarct in the retina in that area. And the advantage of such protocol is that it's easier to teach, to standardize, and also we are not or less affected by dyslipidemia. And we have the choice between 4 sites. So if one site does not is not pertinent, then you can switch and use another site. And the diameter of the arteries are quite standard in the area around 80 micron. And the wall-to-lumen ratio was measured by software developed, either the software of the machine of the RTX1, or we can also do measured on a segment of the vessel developed by Florence Rosen. it's a semi-automatic. This software is semi-automatic with pre-segmentation proposed and manually corrected whenever it's necessary. So this is an example of the adaptive optics montage patient. The patient, this animation covers a 6 months follow-up. This is the first one, second one, and third one. You see there is a regular decrease of arterial diameter, which is surprising because it means that probably at the beginning, sorry, the first one is that one. And the second, here the second, so this is the superior temporal arcade, and the other image is the inferior temporal arcade. To check, we can, this is the first one, second one, third one. So in this case, you see progressive decrease of the arterial diameter, which is surprising because it means that probably at the beginning of the crisis, well, at least at the time we saw the patient after hospital discharge, arteries were actually dilated. Here's another case, and we see the opposite evolution. It's these three images are taking over 18 months. And please note here, so the artery is here, the vein is here, the inferior arcade of the left eye. Note here an area which is constricted, the decreased diameter at the beginning, and this is focal because the diameter here is higher. And during a follow-up, which covers 18 months, you see a progressive disappearance of this focal arterial narrowing. This is another case followed over 6 months. And it's a woman with essential hypertension. The first image is this one. Sorry. There we go. First, second, third. First, second, and third. So there is a progressive decrease in the diameter of the artery. This is a superior arcade. This is the inferior arcade. So it's all over the retinal vasculature again. The decrease in diameter is observed in this case. So we identify the fact that some patients vasodilate over time, some patients vasoconstrict, and in most of the patients there is changes are not seen at the first examination and can continue to evolve despite normalization of blood pressure. All these patients have a blood pressure considered as normal. They were treated by 3 or 4 classes of drugs, very intensive treatment, and we control ourselves the blood pressure at each consultation, and in each case it was considered normal. And so we tried to establish correlation between the diameter of arteries and the perfusion of the capillaries to see if this diameter of arteries could influence perfusion of capillaries as seen by OCTA. So this is a case in which we observed changes in over time in the capillary perfusion, and in the same time in OCT we also detected secondary occlusion, capillary closure, which was not present as first examination but detected 1 month after. And also you see there's an extension of capillary closure. The first image is, sorry, I'm lost. It's going too slow compared to what is expected. So there's the first one, second one, third one, and fourth one. So you see there's continuous change in the perfusion of capillaries despite, again, normalized blood pressure. This is an illustration also of progress of capillary occlusion. First examination here, look here, this area here is perfused, and on the OCTA taken 1 month after, there is non-perfusion in this area here. And this is also appearing here. It's slightly perfused here and completely closed here. And this artery is corresponding to this area here. And we believe that it's the non-perfusion seen here may be in relation to this area of vasoconstriction that you see, and probably the perfusion of this arterial, which has been affected by the vasoconstriction in this area. So these are the overall results. The Wall-to-Man ratio is shown here. There is There are some patients that increase their wall-to-end ratio, some decrease, and this is counterintuitive, but if you increase your wall-to-end ratio, that means you decrease your diameter, it's vasoconstriction. So those going up are vasoconstricting, those going down are vasodilating. And this is the same numbers but normalized to the first exam. Each patient is, first exam is quantified as 1. And so this better illustrates the evolution that we see in some patients vasoconstricting and some patients vasodilating, and some do not change their diameter. What's interesting is that the slope seems to be defined at the first examination and goes on at the 6 months examination, meaning that the difference between the first and second exam may give indication of what will be the result at the third exam. And these are the numbers for the capillary density. It's we observe the same kind of phenomenon. Some patients decrease the capillary density, and some recover some degree of perfusion of capillaries. But there is a correlation between the wall-to-end ratio at 6 months and the capillary density. So there is some kind of correspondence between the diameter of arteries and the perfusion. Unfortunately, we cannot establish if the evolution of the diameter of arteries was correlated to the evolution of capillary perfusion. That we need more cases to obtain statistically significant results. So our study has several limits, of course. It's a very small cohort, only 11 patients. Unfortunately, we cannot see patients at the admission at the intensive care units. Patients are only seen the day of the hospital discharge, and at that time, blood pressure is back to normal. But this, we believe, reinforces our conclusion that vasomotricity persists despite the normalization of blood pressure. So macro and micro circulation obey to different metabolic stimuli. And this may be interesting if we're looking at the specific effect of pharmacological classes on blood pressure. Some may be more active on micro circulation versus macro circulation. But unfortunately, in the small sample that we have, we cannot distinguish between different classes, especially since most patients are already treated with the 4 major pharmacological classes. And so it's very difficult to differentiate anything in this population. There are some issues also related to the severity of the disease. If you have a massive dysedema, it's very difficult to measure anything. And some patients are quite tired and they cannot concentrate for a long time. So that's why also it's interesting to have some reference standard protocol. So if we only need 1 image, if we have time for only one image, then we target the reference zone. And of course, we don't have a standard procedure for capillary density measurement, and we don't have as good images as Richard just showed. Just a slide, and that will be my last. Choosing the adequate parameter for vascular morphometry, I think, is interesting. Wall-to-end ratio is a canonical parameter for vascular morphometry. It's derived from histology. However, if the lumen is occluded, wall-to-end ratio is not calculable, and wall-to-end ratio is negatively correlated to vasodilation. As I said, it's counterintuitive, and so it means that the wall-to-end ratio decreases when diameter increases. So I think it's maybe more logical to use the inner-outer ratio because values are bracketed between 0 and 1. It's always measurable. It's not infinite values. If the lumen is a 0, then wall-to-end ratio cannot be measured. And it's strongly correlated to wall-to-end ratio of just a mathematical transformation. So in conclusion, the arterial hypertensive crisis is accompanied by arterial vasoconstriction and capillary loss, usually followed by vasodilation with some cases of persistent vasoconstriction. The recovery of vascular diameter may take months despite blood pressure control. The cause of capillary loss may involve arterial occlusion. However, we need to further explore this. And the consequences of vasomotricity on downstream blood flow remains to be investigated. That's why we would appreciate having laser Doppler holography in these patients. We can also explore vasculature through neurovascular coupling. An interesting thing is that we can also now, with the transpleural fundus imaging as shown before, have nice, very nice view of columnar spots. It's another manifestation of vascular dysfunction, neuronal dysfunction in these patients. Thank you very much for your attention. So we're exactly on time. Maybe time for one very short question before the talk of Mircea Mujat. I hope I pronounce it correctly. I'm sorry if I do not. No question? Okay, so it's my pleasure to introduce the next speaker, which is Mircea Mujat. We'll talk about laser Doppler flowmetry revisited. Are you there?
Yes. Can you hear me?
Yeah, I see you. I see your slides. Perfect.
All right. Thank you for the introduction. This presentation is about a technique that has been developed at PSI for visualizing and quantifying choroidal and retinal blood flow. And I'd like to start with the disclosure and acknowledgements. PSI holds patents in Doppler flowmetry, in LSDF imaging, and we have a patent application for the subject that I'm going to present today. And we build custom research platforms that we offer commercially to people interested in retinal imaging. All of you know Dan Ferguson, that has been developing retinal imaging technologies for quite a while now, but he retired recently. John Grimble does the SolidWorks design, and Ankit and Gopi helped me with implementing the software for instrument control. And Nick does most of the electronics. For this particular project, we will soon start a study with Gadi Wallstein at NYU Langevin. And I'd like to also to mention the funding sources, NASA and NIH. And I'm presenting today this technique, this instrument, a choroidal and retinal hemodynamics imager that I call the Charmer, that combines OCT and line scanning Doppler flowmetry and enables assessment of blood flow without additional contrast agent in humans and small animal studies. And this instrument provides large area maps of the standard Doppler flowmetry parameters like velocity, volume, and flow. And visualizations. Actually, simultaneously, we get all the goodies from OCT, like 3D structure information or precise velocity measurements. And just to remind everybody the principles of Doppler flowmetry, as in the well-known Heidelberg retinal flowmeter. For example, its laser dyed illuminates one spot on the retina and records temporal intensity fluctuations of the reflected light, and pixel by pixel in a raster pattern. And Fourier transformation of this intensity fluctuations provides the power spectrum, which is then analyzed to obtain flow velocity and flow information. My colleagues at PSI have developed some time ago a line scan approach in which the retina is illuminated with one line and it's imaged with a linear CCD. And that way, the method enables us to record 1,000 pixels simultaneously, and therefore we can image much faster and much larger areas. And once you have the pore spectrum, you can calculate the velocity as the mean frequency, and volume is obtained as the total power of the intensity fluctuations, which is assumed to be proportional to the number of particles within the image pixel. The flow rate is then obtained as the product between velocity and volume. And all this is semi-quantitative because the velocity is given in hertz, and volume and flow are given in arbitrary units, but they provide a very nice visualization of blood flow. And the main question I'm trying to address today is how to get this calibration factor from hertz to millimeters per second in a reliable way all the time. And here are some instrument specifications very quickly. We have a large field of view, about 60 degrees for LSDF, and about 35 to 40 degrees for OCT. The field of regard can be larger than 100 degrees with fixation for human eye and animal repositioning for rodents. We usually run LSDF at about 60 kilohertz line rate, and illumination is at 850 nanometers with the laser diode. OCT line rate is adjustable from 20 to 140 kilohertz at 1060 nanometers for deep penetration into the choroid. And here is a screenshot of the graphical user interface to control the instrument, where we can look at different versions of the LSDF imaging, and in the same time we can see the B-scan live. And here's a gallery of vortex veins imaged with our instrument, and those vortex veins are illustrated by the red star seen here in these images. And I'd like to mention again that there is no additional contrast agent, just light, as in the previous techniques that we've seen these days with the holographic imaging. And all these vortex veins have the appearance of a watershed. It's a collection area that pulls blood into a bigger pipe for drainage out of the choroid. And as I mentioned, one of the significant advantages of this line scanning Doppler flowmetry is that we can image very large areas fast and build large mosaics like these ones. And one can clearly see the retinal vasculature starting from the optic disc. And all the choroidal arteries that start around the optic disc and from the ciliary arteries, and then they spread across the choroid, and then they get collected into the vortex veins. Again, no contrast agent for this kind of ultra-wide field vasculature visualizations. Now, just for comparison, I wanted to show you this scanning laser scanning electron microscope image on the right side, which for a rat choroid, illustrating this long posterior ciliary artery and inferior branch and multiple other branches. It's very similar to what we see in the LSDF images. As I mentioned, this instrument that we developed has an OCT channel, and I'm obviously promoting it as a platform here. You can obtain pretty much all the standard information from OCT. As the reflectivity maps, you can do speckle and phase variance, you can do OCT angiography. But in addition to that, you can use Doppler OCT for precise quantification of blood flow in order to get quantitative values of the velocity. And this is the nice feature that I'm going to use today. So what I want to do for this with this Doppler OCT is to place a small circular scan on one of the arteries or veins that you can see in the live Doppler flowmetry maps. and measure the blood velocity locally at this position. And if I measure the velocity with the LSDF, with the standard Doppler flowmetry, I can get this calibration factor, and then I can apply that quantification, that calibration to the entire LSDF developed map. And the geometry is like this. We always scan from a stationary point, A, which is located in the pupil of the eye, or at least that's the intention generally. The OCT beam sweeps over the surface of a cone, which intersects the flow twice in two different positions, as you can see in this image at the top. And as we measure the height position of these spots, the axial location, we can determine the angle between the OCT beam and the velocity vector, the blood flow. And because Doppler OCT only gives us the axial component, we need this angle in order to determine the absolute velocity. And we tested this concept in the lab using some cylindrical glass tubes that were embedded in a tissue phantom with different diameters on the inside, and we can flow diluted milk through these tubes in controlled conditions using a syringe pump. And we can also control the orientation of these tubes more or less within some limits with respect to the imaging system. And I'm showing here a few examples of these different situations for different tube diameters on the left and for different orientations of the scan with respect to the tube. As you can see, different heights for different orientations. One problem with Doppler OCT is that as you increase the velocity, the phase wraps, and you get this kind of ring appearance. But there are plenty of 2D unwrapping algorithms available, and what we can do is apply them to obtain this kind of nice parabolic profile, and we actually obtain this in a two-dimensional space. And here are the results of our angle measurement for the 3 different tubes shown here with different colors and different orientations. The calculated values are not exactly the ones we intended. There are some small differences in here, and that's because there are probably some compound angles in the positioning of the glass tubes that I cannot really control very well. Since we're talking about these small angles. And what's remarkable, however, here is that the calculated values are pretty consistent over a large range of velocity, as shown here at the bottom, up to 100 millimeters per second, with some errors at the very slow flows. Now, Doppler OCT, again, gives me the axial components, and now that I know how to calculate this angle, we can calculate the absolute velocity. And these are the results for our testing for the 3 different tubes at different orientations. And you can see a very nice linear dependence between the measured velocity with OCT and the set velocity from the syringe pump over the entire range of 100 millimeters per second. Another nice advantage of this type of circular scan that cuts perpendicular through the blood vessel is that you get a parabolic profile, as I was showing earlier, from the phase. And if you do a fitting, the points of intersection of this fitting with the horizontal axis will give you the diameter of the flow. Obviously, the assumption here is that the velocity goes to 0 at the wall. And here are the results that we obtain in measuring the tube diameter for the entire range of velocities, more than 100, 120 millimeters per second for the 3 tubes. And again, some small errors at the very slow flows, but in general, the results are pretty decent. Now that we know how to measure the velocity and the diameter of the tube, we can calculate the volumetric flow rate Q, as I'm showing here. And there is, again, a very nice linear dependence between the measured flow rate and the set flow rates. We've also tested the reproducibility of the measured values of the velocities and angle and diameter. And we've done the same thing basically 10 times, and the relative error is relatively small. And I'd like to also mention here a very interesting aspect of this small circular scan that we're using, this geometry, as we can see in the imaging of human eyes, is that if the two spots are at the same height, what you get is basically one positive and one negative phase shift. And that is because the axial components is towards the imaging system or going away from it. But clearly, once you know the angle correctly, that compensates and you get the correct value of the velocity all the time. If there is some certain height difference between them, both of them could have the same color. Now let's see what we can do with the laser Doppler flowmetry. In a very similar way, we can do a fitting of the volume or of the velocity profile across the flow. And again, the intersection here at the bottom with the axis gives us the diameter. And this is an example of the results that we obtained for one of the tubes that's supposed to have, according to the manufacturer specifications, about 280 micron diameter. And the measured velocity in kilohertz looks like this. And we can immediately see that there is a little bit of a problem here. This kind of non-linearity of the measured velocity in kilohertz as a function of the set velocity. And I think there is a simple explanation for this kind of non-linearity. If we look at the power spectra, which were normalized to the average power spectrum, the mean over the entire image, some sort of a background power spectrum for stationary tissue, you can see that as the velocity increases or the flow rate increases, this kind of bell shape of the spectrum moves towards higher frequencies. And the problem is that the measurement is limited to half of the line rate, and we're doing measurements here at 90 kilohertz. Therefore, we cannot measure frequencies larger than 45 kilohertz. And if you try to do an average of this kind of profile, obviously you get a wrong result. But as I mentioned, we get this kind of profile that plateaus towards higher velocities. But once you do this kind of calibration, we can see the data with a function that looks more like the error function. And there is clearly not a single proportionality factor between the measured velocity and the set velocity. It's basically a function. And once we know this kind of function, we can inverse it and we can calculate the correct velocity for any value of the measured velocity obtained in kilohertz. And now that we know this velocity and the tube diameter, we can calculate the flow rate, and we can obtain that in the correct units of measurements, microliter per minute, for example, here. And there's a nice linearity between the measured LSDF flow rate and the set flow rate from the pump. We can look at this in different ways. We can do a comparison between the ratio between the flow rate obtained with OCT and LSDF as function of the set flow rate, and the ratio is pretty close to 1. Or you can look at the LSDF flow rate as compared to the OCT flow rate that we measured with the system. And in conclusion, I hope I did convinced you that the LSDF is a nice global flow visualization technique that was semi-quantitative until now, that we can identify, quantify retinal and choroidal blood flow with these two complementary techniques, the LSDF and OCT, in the same instrument. We can use OCT as a local probe to measure the absolute blood flow velocity and calibrate the LSDF maps over very large areas. And the combination of these measurement techniques within the same instrument provides a powerful diagnostic imaging tool that could help us better understand the hemodynamic processes in the eyes. And I'll stop here. Thank you.
Thank you very much. Thank you very much for a very good talk, and we're exactly on time. And now it's time for Anne Eisner to talk about cone distribution and retinal vascular changes in diabetic subject without retinal thickening. Anne, are you there?
I'm here, and the screen share just disappeared. So let me try to make this large field. Here we go, it's back again. All right, so let's see. I'm going to share my screen and let me know if you can see it. It's not yet in slide presentation mode. Can you at least see the screen?
See it? Yes, we do.
Perfect. Oh, and the other thing is my last name is actually Elsner.
Oh,
So,
sorry.
yeah,
Eisner,
I have a close friend named,
yeah.
yeah, I have a close friend named Al Eisner, and we always thought we should put a paper out, Elsner and Eisner, you know.
On my cell phone, I don't have my glasses, I'm sorry.
No, that's okay. So, well, I'm happy to be here. I've been enjoying my 3 days. There was a little bit time shared with teaching responsibilities and other things, but I've seen quite a few interesting talks. So thank you for the organizers for putting together such an interesting group of papers, many of which are about one of my favorite topics, which is retinal blood flow and the vascular aspects of the retina. So I'm going to be talking about both cone distribution and retinal vascular changes. And this is part of Steve Burns's longitudinal grant. It's an R01 and we're in our second phase. And these diabetic patients in this longitudinal study come in with no retinopathy, mild to moderate proliferative diabetic retinopathy. But then it's a longitudinal study, so they might be advancing onwards to far more extreme. So we picked out a couple of years ago just one of the cross-sectional groups that were tested 2018 to 19 with all the same techniques. So bear in mind, we've been counting cones quite a long time. And we've been doing that with AOSLO. And on the left then, I'd like to show you a typical normal control subject. This would be 100 micron spacing here. In this kind of image, you can easily count all the cones, no problem. However, once you get a little bit farther away from the fovea, the cone distribution might be somewhat less regular, and then you get these super bright things in diabetics, so it makes the enumeration of cones difficult. Now, if you think about counting cones in diabetic patients who actually have retinal vascular changes, so here's an example, we'll be seeing more of this later, some microaneurysms, and can you see these fine capillary changes here? We have horrible retinal vessel remodeling in patients that are supposedly having very mild to only moderate clinical staging. So we are having to look through all of this to try to enumerate and quantify cones, which is a bit tricky. So this is in a reflected mode with AOSLO. And these two on the right here, this is just two different samples in an eye. This is with offset apertures, again, AOSLO. All of this is near infrared light that we're looking at here. So you can see that there's these vessels that are elongated, and you can see tangles, etc., thickening, besides not just microaneurysms, but the vessels grew. So basically what's happening here, to a different extent in all 10 of the patients in this cohort, is that they are having a response probably to ischemia, and they are putting together excess endothelial cells. They're elongating their retinal vessels, tubule formation, and then the vessel to nowhere, it's goes here and there and everywhere else. But all of this is happening while we're still trying to count these cones. Okay, oh, and no commercial, because I asked Ethan Rossi which he'd like to hear. Would he rather have line scanning from my company, Eon Imaging, both wide field and AO, or would he rather have diabetes? And he said, do the diabetes. So here it is. So this is my collaborators. And I want to put your mind in the frame of thinking about cones are marvelous, cones are wonderful, and they live despite their horrible microenvironment. So this is a bunch of published images that Steve Burns took in 2013. And this is actually AMD, but I wanted to show you confocal on the left and multiply scattered light with offset apertures on the right. And this is over outer retinal tubulations. This is when the cones and nuclear cells wrap up and travel across the retina and don't die right away. And on OCT, they look like this. So we've been following patients with this, but you don't usually see this sort of thing in diabetes because the RPE is not dying off, but you do see it in progressive retinal degenerations. And the shocking things is the cones are still alive. Okay, so in diabetes, the microenvironment of the cones is greatly affected by changes to the inner retina. Everyone knows that. And the breakdown of inner blood retinal barrier and vessel remodeling. And clinically, this has been typically classified in the ETDRS, the International Classification, and IPACS. Finally, we're getting to some good OCT classification schemes that have a little bit more. But don't forget, there's outer blood retinal barrier, and that's also affected early. And the RPE is sitting in ooze, or the choriocapillaris is not having intact endothelial cells, and the RPE may not be able to pump properly. So you might not have the tight junctions that you need, in which case the photoreceptors might be sitting in some fluid. And we've known this since the 1980s early. And we've shown this with imaging from my lab, Arthur et al. But this is also seen in animal models of mice and or rats in which there's high glucose. So when you use various imaging methods, diabetics have more obvious damage to their inner retina if you're using the kind of techniques that show you the inner retina. So color photographs are showing you the exudates and the microaneurysms, etc. But there's more there going on. And if you use longer wavelengths, we show that you can penetrate more deeply and see a bit more of the cysts in the outer retina, etc., with ordinary red light of an ordinary fundus camera. And on the left, we're going to see a bit more of those loops. This is from Burns et al. 2014. This is a 31-year-old male patient who had all this kind of vascular remodeling going on early, even though clinically his eye looked really good. So that's sort of the background I want to put you in. Now let's summarize that. Cone distribution, there are large individual differences in the normal controls. Okay, microenvironment. Oxygen availability is going to vary even in normal eyes, particularly in the macula, different size foveolae vascular zones, etc. Size and shape of the foveolae vascular zone really differs a lot. And so the distances between capillaries can also be different. Cones are surviving in a harsh microenvironment. We showed extreme examples with AMD, but what's happening in diabetes? So cone distribution and reflectivity changes. So the cone density outside of some areas of damage can actually be higher rather than lower. So do cones move to a more favorable microenvironment? And then Sweetis et al. In 2017 showed that there are some dark cones, I'll be showing you more of those later, that it's not just a cone here, a cone there, but it's a larger region. Okay, so here are some of those, and we can see that there's dark regions here, and then here's a blow up here to show some of the features, and these are several cones long, and it happened over a period of 1 year in the patients who were followed. So what is this? If the cones are most likely present, but they're not guiding light, then there's probably deep to the retina fluid that is preventing the total internal reflection. So the cones aren't guiding light properly. Okay, so we use both AOSLO and OCT with OCTA, and we use the IOL master to get the axial lengths to correct for size changes when we're doing computation of density. And I'd be happy to answer any questions about the types of AO that we do. Okay, here is kind of the main point, and that is we took our age and sex-matched controls from our fast Fourier transform study of very early diabetics. And this age range perfectly matched the cohort of 10 from Steve Burns's lab. And using these as controls, then we could form confidence limits for all the quadrants for OCT thickness. And I'm just going to do total retinal thickness. So we were counting cones in this study in the fovea and nasal and outer nasal. So those are the quadrants we care about. And in every single diabetic subject, in every single measurement of total retinal thickness, they never had either thicker or thinner measures than the control subjects. So therefore, we have these vascular changes of the type that I showed you, but we are not exceeding our normative value on the same instrument. So they would not have edema by thickness criteria. Okay, so however, there is something interesting. In this group of subjects, these are a little bit more advanced than our FFT patients were. So these subjects have some signs of something. And the statistically significant correlation with age showed up. So the older eyes have somewhat thinner total retinal thickness than the younger eyes. Again, none of these people ever falls outside of the confidence limits though. So these eyes that we're talking about have this sort of thing going on, but they're not thicker and they have overall thinning with age retinas. So you could suspect some neural damage in them. Okay, so the previous results for cones, here we have, as you measure from the fovea outwards, you have fewer cones per unit area, density decreases. There's enormous differences among the foveal regions. And this is in 36 young subjects who are more or less emmetropic and had healthy eyes. Okay, so now going to the diabetic subjects, I have two kinds of montages here. This is a cones montage at the top, and at the bottom we have a little bit more superficial, and that's showing more of the vascular changes, the microaneurysms, etc. But as you can see back to the top, you do still have to image through these vascular things. So how do we do this? Do we follow our rigid protocol that we've used for a million years? And the answer is no. In fact, we actually changed our protocol so that we are going to sample where we can see the sample, and then we're going to use an exponential model to know if that's the normal numbers of cones or not. So here we have, again, these extra bright cones. So you've got these extra bright cones. And if you can see on the top, there's regions where there's just areas, it just looks too bright, little patches. And you wouldn't see this in a normal eye. Okay, here's a second eye. And again, here's some of these splotches of the extra bright cones. Okay, now finishing up a little quickly here, I hope. So again, we have to say there's differences between younger eyes and older eyes on average. And we published this years ago. And the main thing is you see more obvious differences in the center, but they do exist somewhat outside the very center. But the main thing is you just don't have these very, very high peaks in most of the older subjects that you do in the younger ones. Therefore, when you're comparing what's normal for control subjects to diabetic subjects, unfortunately, the confidence intervals in older subjects get huge. So another thing we want to point out is if you model how many cones you have as a function of eccentricity, it isn't just that some subjects have overall more, like 1.5 times more. It doesn't work that way. There must be two parameters to explain how cones are distributed. And the thing is that central cones may, in fact, not be particularly related to the more peripheral cones. But if you normalize how many cones there are in the more peripheral locations to the central ones, you see a good linear correlation here. So basically, we use then an exponential model, which works well for young, healthy eyes. There's more variability in the diabetic eyes. So, you know, I feel a little bit not as confident about my parameters. But for the younger eyes, here we have the A parameter, which is describing the slope as you decrease cone density from the fovea. And the B parameter, think of that more as an asymptote. So for the two younger subjects who were diabetic, they fall well below the confidence limit for this B parameter. So fewer cones, yeah. And then here's some older subjects who are also trending downward. Most of the subjects are less than the average, and this is the average for the age that's older. But the thing is, there's so much variability that you know, it's hard to get outside of the confidence limits for older subjects. Okay, here's where we applied the model to look at how many cones might you have in the central 14 degrees. So we basically modeled with the exponential model in little rings as we go outwards. So here's total cones, and here's our parameter B. And basically here's younger subjects, or 36 younger subjects. Here's older subjects. You see there's this huge variability. And here are diabetic subjects. So down here we have, these are the two younger ones, so they're clearly falling outside. They have fewer cones in the central 14 degrees. But there were countable cones in all the subjects. So even though we had those vessel changes, they're still countable cones. It's hard to say, are there fewer cones or are they just distributed in a more variable or unusual way because of this large amount of variability. But basically there are people who have overall fewer cones in the central 14 degrees than do others. So what we need to do next, and haven't finished, is to look at our vascular parameters and see if these are tightly linked or if cones are providing a different type of information. So I'll close there. Thank you.
Thank you very much. And we have time for one or two short questions for Anne. I think there's a question in the discussion. Q&A, there is a Q&A. I don't know who has addressed this question. Very exciting work. We are seeing similar findings in our studies. I was wondering if if you had more information on the dark zone, did you see growth of the area over time? Do they have any particular property? You took note, it's a very long question. You took note of to define them as cone loss areas. Did they associate with any hyperreflective brighter cell type areas? Might have to follow up on this over email here, of course. If we would, it would be okay. Really great talk.
I can answer some of that, but not all. As you know, COVID was a big disaster for many of us. And the only ethical thing for us to do was to close down the laboratories. We recruit in our patients, and we could not see that it would be ethical to bring in people with diabetes into a university classroom environment. These are not clinic patients. They would have to come to a building where there were unmasked students, then finally masked, but unvaccinated students. So, we've got that pretty much cleared up, but we basically had to shut down the labs a year ago, March. So we couldn't follow up. We do in the Sweeties et al. Have follow up. The zones continued, but they didn't necessarily grow, but that wasn't enough time. The OCTs, unfortunately, are at pretty decent spacing, but there wasn't enough room to really always tell exactly where the OCT B scan line was compared to the dark cones. So when we could find them, there were things on the OCT, but often we can't. So then you're going to ask me about, we actually haven't finished analyzing the offset aperture data. So the very old dark cone data subjects in the Sweeties et al. Study, the Sweeties et al. Was published in 2017, and the sample I just showed was 2018 to 2019. So some of them will be the same people, but some of them will be new. So we can go back and find out, who were the ones from before and look there. But the main thing is that there wasn't offset aperture images back in, say, 2011. So some of these people will predate that. There has been for maybe at least 10 years. So we will be able to do that, and we'll be able to investigate that. We haven't done that yet, because the main emphasis of the time I've been spending is to try to compare the AO-SLO capillary mapping through motion mapping with the OCTA, which has some challenges, but if I could just get these 10 people and also the OCTs, I will be very happy. That's like my goal is to get that for ARVO. And then after I do that, then I'm going to go to the offset apertures.
Thank you. So for the sake of timing, I'm going to introduce the next speaker, which is myself again. And I'm also delivering a speech because of the absence of the principal investigator, which is Sophie Bonnet. And she agreed to let me do her talk. Well, I don't have the screen share. Yes, I do. Let's try it again. Okay, what's going on with the screen sharing? There it is. Got it. I think you don't see my screen. Is it correct? Yeah, now you see it. And I hope again. So parameter. Okay, I think I got it now. So on behalf of Sophie Bonnet and the team of Paris Group and also the team from the Hôpital Lariboisière, we'll talk about the high-resolution longitudinal imaging of diabetic retinopathy. So as Anne already said, diabetic retinopathy is a major cause of visual loss worldwide. The there is an association of microaneurysm and non-perfusion that leads to severe damage comprising retinal edema due to rupture of the blood-retinal barrier and or capillary closure. And so there is a long debate about the respective role of non-perfusion causing microaneurysm or microaneurysm that are independent of focal non-perfusion. This is illustrated here. It's very common to observe that when you see a microaneurysm, it's an area in which there is already a non-perfusion. However, surprisingly, recent histological studies have challenged this concept, that finding that many areas comprising the perifoveal area, there doesn't seem to be a clear relationship between the presence of capillary occlusion and microaneurysms. And in recent years, thanks to the work of many teams, some of which are presenting here today, there is been a huge progress in the imaging of the lesions of diabetic retinopathy by adaptive optics ophthalmoscopy. Some researchers have shown that these capillary abnormality may change in a relatively short time scale. You see, within months, you can observe considerable remodeling of capillaries. The team of Chui and Richard Rosen shows nicely the anatomy of the microaneurysm, seeing here the red cell and here the intraluminal deposition of plasma material. And also the Mayer Saleh from Besançon and now in Lebanon have nicely shown that we can detect microexudates during macular edema. And we've been also interested in looking at microexudate, which seems to present in all cases in these small little spheres, approximately 10 micron wide, that can aggregate. And they're very dynamic structures, as you see on the animation here. They can be, this is a follow-up time-lapse image taken approximately every month. And you see there's a considerable change in general tendency to aggregate. So, as I said in the introduction, capillary occlusion, microaneurysm, and blood-retinal barrier during diabetic retinopathy may occur simultaneously, separately. It's not very clear how they influence each other. It's a chicken and egg problem. It's been long known by histology work that microaneurysm are occurring in areas with capillaries that are not populated with endothelial cells. This is a classical image from a work from the 90s, and here is a confocal microscopy of microaneurysm and showing the phantom, what we call gauze capillaries, or capillaries which are not circulating anymore red cells. And we can also, thanks to this optical sectioning property, we can also identify the presence of intraluminal material in these microaneurysms. So histology has shown more clearly than in vivo imaging until the recent year that capillary dilation is also an early feature of diabetic retinopathy. And most microaneurysms seem to occur in the deeper layer that is in the capillary or post-capillary layer. So to now, there's unclear spatial relationship of capillary closure and microaneurysm, and it's difficult to assess blood-retinal barrier rupture by histology. One of the reasons that lipid exudates can disappear during tissue processing. So the purpose of our study is to explore the natural history and spatial temporal relationship of microaneurysm, capillary dilation and closure, and blood-retinal barrier. For this, we use OCTA, flood adaptive optics imaging with the RTX1 camera, and AOSLO using PSI in bright and dark field mode. And we repeated imaging session typically once per month. And this is an illustration of the imaging we're doing in each patient. This is a AOSLO motion contrast just by extracting the standard deviation the video of the AOSLO with extract features that change over time. And this is vessels. This is a further better definition of individual vessels than OCTA. However, with probably imaging is selective of most innermost capillary layers. So this is I'll show you two cases which we've been examining in more detail. The first case is a patient without any macular edema. The only thing you can notice on the scan here is some irregularity of the inner nuclear layer, probably denoting the presence of capillary non-perfusion, which is confirmed on the OCTA, which you see here, a depopulation of capillaries and some macrovascular abnormalities. On the flood adaptive optics imaging, you can also see the same zone with a slightly better resolution. And indeed, there is a elongation of capillary forming a loop, which is more clearly seen by the RTX1 than by the OCTA. And we follow this patient is still undergoing a follow-up, but as I mentioned, there are some issues about seeing patients in the COVID period. So we have the opportunity to see this patient twice at the 3-month interval. So this is a fovea seen by the RTX1, and in the middle you have the microaneurysm on the probably located on the foveal on the perifoveal ring, and in the square you have some capillary loop, and within 3 months you can see there is a significant change in its shape. So we can indeed document changes in despite the absence of or the very moderate stage of diabetic retinopathy. The disease is already quite active even at the early stage. These are images of the same eye of the patient, showing again follow-up images. So we have here venules and arterials and a capillary loop on the bottom of the image. And we're close to the fovea. And then again, in 3-month interval, you can see the increase in diameter of the capillary accompanying, especially in the area showing a capillary loop. But these, it's interesting to note that such change in diameter affect as well arterioles, venules, and capillaries. Another illustration here. So short-term change can be identified quite easily using the RTX1. And there's another case here, a 32-year-old man, type 1 diabetic with minimal to moderate diabetic retinopathy in one eye, nothing in the fellow eye, nothing really on OCTA, no non-perfusion, and we concentrated our attention on the fovea. In the fovea, you see some capillary loss here, inferior to the fixation point. This is the RTX1 image showing numerous exudates with microaneurysm here. Note that the microexudates seen here on this bright field AOSLO imaging seem to aggregate around the microaneurysm. This is a bright field AOSLO and the dark field AOSLO. So this is the RTX1 OCTA dark offset AOSLO and the motion contrast. So note that on the motion contrast image, we see some features here, microaneurysm here, one here, and the one here that's detected here. But the OCTA fails to demonstrate the presence of these lesions. And the motion contrast shows this, which is visible here in the video. Sorry, I have to click iteratively. You see a microaneurysm here, another one here. The rotation, the apparent rotation of red cells. There's a 2 microaneurysm, and also you can see a circulation in this microaneurysm here. And motion contrast image captured the motion of the red cell, which does not populate the entire zone of the microaneurysm, but only a part of it, the rest of it being probably filled by deposition of plasma material. And note that the OCT also only can detect the part of the microaneurysm showing red blood cell circulation. And this patient was followed up during 2 years. There it is. The video is supposed to turn. There it is. So this patient was followed up during 2 years, and this is a fovea. Again, the same image. So now we start with the first image. Note here for the macroaneurysm stayed there. You will note that there is one microaneurysm that disappears. Note also the presence of cysts in the fovea that appears and disappear, and the dispersion of micro-hard exudates, and the apparent migration of a large aggregate of hard exudates. This is one of the last imaging we follow up, and we were intrigued by this disposition of microexudates, and this matches perfectly the anatomy of the perifoveal ring, showing that these microexudates tend to accumulate along capillaries. We also wondered if we can detect better the other some features of blood-retinal barrier, and the micro-hard exudates are obviously the best candidates for analyzing the blood-retinal barrier. It's easier to document than cysts, for instance. And we also, yesterday, the first day of the meeting, Wednesday, Nate Norberg showed you the nice images of gaze-dependent imaging, which helps to identify drusen, such as in this image here. And by differential imaging, we can extract the features of the drusen. This is always also true for hard exudates. You see here the hard exudate I showed you. And this is the superposition of images taking different gaze direction. And this standard deviation image can also nicely show these hard exudates. And more recently, we were interested in other imaging features such as transscleral imaging, and also transscleral imaging also gives a nice view of the microexudates as you see here. And finally, we hope that the new Merlin system developed here with ImageNI and with the Denmark team can also help to better characterize the presence of these microaneurysms. So this is my last slide. The evolution of diabetic retinopathy can be documented over a short time scale using high-resolution imaging. Longitudinal multimodal high-resolution imaging contributes to a better understanding of the early steps of diabetic retinopathy, the life cycle of microaneurysms, capillary dilation, loops and closure, circulation and turnover of small hard exudates, and small edema cysts. The novel imaging approaches may further improve these explorations. However, there are some technical issues we have to face, and that will be the job of Sophie Bonin in his PhD. First of all, edema modifies the spatial relative disposition of retinal features, so it's easier to document cases in which there is no or minimal edema. Flood, adaptive optics, and areas both has advantages and drawbacks, but we believe it's really better to combine these approaches. We have some issues with the contrasts of motion contrast images, in particular in deeper layers. So we have to check if we can also capture capillaries in the deeper microvascular layer where occurs most of the microaneurysms. And we have some difficulty in the detection of ghost capillaries and ghost microaneurysm. We see them very clearly by histology. It's a common finding. Capillary never really disappear. They always leave a trace, but that trace is difficult to image by what we have for examining patient. Maybe AOCT will help us to detect them. And we would like to have another way than detection of hard exudates to detect the blood-retinal barrier rupture, maybe mapping small cysts throughout the retina, maybe again by AOCT, will help us to have a better in vivo characterization of blood-retinal barrier without using fluorescein angiography. And that's it for me. So this was the last talk of this meeting. I'm gonna stop my screen share. Are there any questions for all the talks of today, of this last session? No questions?
I have a question. I have two, actually. I have a single question for your talk, and then I have a group question for the previous talks, several of them. So I'll tell you my group question first, and that is, we just heard quite a few things about blood flow, hypertension, etc. And some of you are clinicians, and so I would like to know, I know that there wasn't a strong finding for beta blockers, because in the study in which, you know, the different treatments were shown, there was 4 different treatments. But I am, you know, kind of wondering what the thinking is about vasodilation and beta blockers, and are we seeing it with either AO, SLO, or OCTA? Is anyone really seeing something specific about, beta blockers and vasodilation? So
Not-
then I just wanted also to say, I love those little cysts. They were gorgeous that we just saw. And, like, do 200 little cysts equal like 2 big ones? Or do you have any ideas? Like, is it really bad to have a lot of little ones, or is it worse to have the big ones?
Yeah, that's a very good question. It's surprising to see that the retina is very tolerant to edema. You can have major distension of the retina, and after treatment, it comes back as it was, nothing happened. So it's difficult to answer the question, and it depends on patients. Some have small cysts and have very impaired in their vision, and some are large cysts and seem to have 20/20 vision. Even a single large cyst in the fovea, you can have 20/20 vision, because there are many factors influencing vision probably. Then if you have a small bubbles throughout the fovea, then it may disperse light and then you lose vision even without neuronal damage. So that's not really an answer I'm providing you, but I think there's other factor than just the cysts. There is a neuronal glial degeneration, and it cannot be appreciated merely by quantifying the volumes of the cysts.
So years ago, John Marshall did some work that sort of indicated that it wasn't so much the amount of cysts or the size, but how much residual the columns of the Mueller cells were still intact. That seemed to correlate better with visual acuity. So that was done with really early time domain. I don't think that's been repeated on some of the newer on-FOSS imaging. Which
is difficult to document currently with what we have current OCT. Maybe again AOCT or maybe specific protocols using AOSLO may identify if there's any, let's say, residual column of cells that may establish a contact of if there's nothing left. That could be something to look at.
Mm. Still up for grabs.
So is anyone going to jump at my beta blocker question or vasodilation in general? Like, what are the pathways that we can measure there? Is there, like the effects of treatment? If the effects of treatment are minimal, can we see some effect of treatment and try to understand in whom it is minimal and who, and who is actually getting an effect? I mean, can we really see that going on?
Who wants to answer?
I don't know if it's sensitive enough. I mean, you'd have to probably set it up in a, the one of the issues is, of course, a lot of times the patients who are on a lot of medications, there may already be changes in the walls that will not let them dilate quite as easily. And maybe if you wanted to test that hypothesis, I would probably think that you'd be better off doing some sort of local treatment than putting it in systemic, which would tend to be slower. But I've never seen anybody actually look at that. It's an interesting question, though.
We've been frustrated by our study on blood pressure because chronic hypertensive patients don't show many change, and acute hypertensive has so many drugs we cannot distinguish anything. But I think the good thing to understand is that even very severely narrow arteries can dilate. I think that's, we were surprised to find in some subject that we have in mind a patient with, I think was 80. He was kidney disease and terminal kidney disease, very severely reduced arteries. And 2 years after, the artery was back to normal diameter. So I think we should not look at the arteries as being fixed and sclerotic. They maintain the capability of vasodilation and constriction. And it's only because in aging, the vasoconstriction is stronger than vasodilation, but I think it can be reversed. And I really think that, at least for small vessels, I'm not talking about large vessel, it's atherosclerosis, totally different. There is sclerosis in atherosclerosis, but that does not affect small vessels, such as in the retina.
Good point.
Any questions for the other speakers? I've got a question for you, Richard. Indeed, about vasomotricity. Are there vasomotricity phenomenon in sickle cell disease, and can it contribute to the disease?
You said, what was the term? I couldn't hear it very well. You said,
in sickle cell disease, are there vasomotor phenomenon, vasoconstriction or dilation that may contribute?
Right. There, I think there are, depending on the because basically the disease is more of a traumatic structural injury to the walls, and you definitely see patients, that have a lot of constriction, varying constriction, probably after damage to the walls. I see a lot more of these patients now because the work that we're doing with the hematology department, and there definitely are, I don't know whether how permanent these changes are, but you see increased tortuosity typically in some of these patients. So I would, you also see areas where it seems like you have vasoconstriction, but it's not really a inherent to the disease. It's more what has happened when these endothelial cells are injured by these sharp RBCs. So it's a little bit different than in the diabetics. It's
also a follow-up question for you. Maybe you mentioned it, but does it affect superficial or deep vascular layer of the lesions of these patients? I forgot what you said about that.
You actually see it in both. I mean, we looked at the full vascular layer, so we included the superficial and the deep together. So we didn't in our capillary analyses.
But in most cases, it's pre-capillary and small arterioles or capillaries. That's what it's not never in veins. That's
right. So they tend to be on the arterial side of the capillaries. At least that was what this particular way of measuring it seemed to indicate. It's always very dependent on your technique in terms of what your answer is.
I saw there was a question for Richard in the question on the Q&A earlier. It came from Johnny Tam. Do you know how often intermittent flow is observed in either healthy subjects without SCD or another disease?
Well, that's actually why we created the normal sort of reference group from the controls. There is some degree of opening and closing, and you see some normal recruitment where certain vessels may not be active at any particular time. So we try to rule those out. We see it in diabetics, which was when Dr. Chewy noticed this first in some diabetic subjects in a paper that was published a couple of years ago, where we were looking at using ENFAS OCT, comparing it to the OCT angiography to see where the vessels had been lost. And so we found that there was a whole range in the diabetics in terms of intermittent closure. And you probably do see it in normals to some extent. So we have seen it in some of our controls as well with AOS alone. But I don't think it's as much, because there's usually the red blood cells are very, very soft. They're more in the consistency of like an oil droplet than these sort of hard sort of plates.
If anybody in the audience have a question, you can raise your hand so you can open your microphone if you want to talk to the speakers.
So I have a question for Mircea. I really like that device that it looks like you're finally able to measure, volumetric blood flow you've solved the problem that the Heidelberg had of not being able to have any sort of definite numbers. Have you looked at any pathologies with that yet, or is it's still early?
We will, the development of that system is part of a phase 2 NIH program, and we're going to bring that system to Gaudi, to New York. And we'll see what kind of eyes we can image with that.
Yeah, that's very interesting.
So far, we only used it for a study on small animals, on rats, with the retinal degeneration, and we see significant changes in the velocity in the blood flow between normals and rats with the retinal degeneration. We haven't published anything yet.
You know, it would be really, I think, very interesting as maybe an early way to follow diabetics before there are changes. I mean, a lot of the early changes that we see in OCT angiography you may be able to see in terms of volumetric flow change, very subtle changes. So you know, hopefully it will be successful, because we'd be interested in working with a device like that.
Thank you.
Mircea, maybe I can follow that question just to ask, how would you compare your system to the laser Doppler holography that we saw from Michel at the beginning there? You have some similar features that you're imaging, but maybe the specifications will be quite different.
Yeah, what we have is, I think, probably a little bit larger field of view, but that you always have to lose something for that. You lose probably a little bit of resolution. But the technique that we have, the standard Doppler flowmetry, does not have any sort of axial discrimination, as opposed to your holographic technique, which gives you the entire three-dimensional kind of distribution of blood vessels. But I think the addition of the OCT channel for you to place it on one of those vessels and monitor and precisely measure the velocity on that would be, I think, a great feature for your systems.
Okay, no more questions? Maybe it's time to conclude. What do you think, Ethan and Kate?
Sure. Yeah, it's been a really great meeting. So I have just a couple slides that Kate and I want to show here at the end. Can you see my slide?
Yes.
All right. So thank you all. This was a really spectacular meeting. We had some really nice sessions. I just wanted to sort of review again for those of you that weren't here at the beginning, or just to summarize for those of you that were, where we came from and where we're going from here. So the first meeting that we had with this group was in 2018, and it was just a one-day course that was addressed principally to clinicians and had practical training sessions on clinical devices with a few invited speakers, including me. It was my pleasure to be able to join for that first meeting. The second year, we expanded the program to include both clinicians and imaging experts with a focus on AO and OCT. Again, we included practical training sessions on the clinical devices and had several invited speakers. Last year, we had intended to have another in-person meeting, but it was transformed to a webinar on Zoom. And we had really ton of submissions last year. So we had a large program with 50 speakers and had a format that included both long talks and shorter talks, and had many spectacular invited speakers. here for this meeting. For those of you that were at all the sessions, you know what we did, but I think many of us have come in and out. So I'll just sort of summarize that we had 36 speakers this year, drawn from 10 countries with uniform lengths. Kate and I decided we had such great submissions this year, and we had a reduced number that we were able to program everyone in the same format with these expanded discussion sections that were really great, giving the opportunity for us to discuss in panels. And just to review the sessions we had on photoreceptors the first day and anterior segment and glaucoma. Yesterday we did eye movements, AI modeling, and histology in animal models. And then today, our session this morning on novel technology and the one on blood flow that just concluded. I just want to give a special thanks to all of our invited speakers that are listed here. Also want to give a special thanks as well to all the moderators. Thank you all for dealing with the technical challenges that have cropped up. Different ones each day, but they were handled so well and so smoothly. Maybe many of the participants didn't even know that these were going on. Next year, we hope to be off of Zoom and to be able to see you all in Paris. I don't know, Kate, if you wanted to say anything about next year. I think the plans are still developing.
Sure. I was just going to say that what we would like to do, if we can really have an in-person meeting, it'll be really exciting to have everyone on site. And so we'd like to, shift the focus back towards the training aspect. So give more practical demonstrations of the technologies in the imaging platform on the clinical aspects and the technical aspects, and also include poster sessions for students and other contributors. And that's partly because, maybe you can switch on, I think you have a slide. There's a meeting happening next year, which is happening close dates to the i2Eye meeting, which is in Australia. It's the ISER meeting. And along with Joe Carroll, myself and Joe Carroll are organizing the ocular imaging session for that. So there should be a lot of really good speakers at that meeting, a lot of which you've heard in these last few days. So that will be a real opportunity to hear, to get the best updates in ocular imaging, and to hopefully be all in the same location in Australia. So in view of that, we've decided that i2Eye will try and focus on the training aspects to be complementary to what some of us will see in the Australia meeting.
And then, thank you, Kate. And then we're hoping in 2023 to be able to bring people here to Pittsburgh and welcome them to our new facility that is under construction now. I drive by the construction site every day on my way in, and it's slowly marching up into the sky. And we hope it will open next year, and we'll move in then, and that we'll be able to welcome you to this new state-of-the-art facility that's going to house all of our clinical and research operations that are now spread amongst several buildings and one site. And so we hope that we'll be able to invite and bring speakers here to Pittsburgh to see us. So with that, I think we can conclude the meeting, and thank you again to everyone for their beautiful presentations, masterful moderating, and we look forward to seeing you again soon.